So good morning, everyone, and I think we'll start with the next instruction course. That is, can you give me the first slide, please? The next we are discussing is how to prevent trabeculectomy failures. So trabeculectomy still remains a most frequently done glaucoma surgery to control intraocular pressure. And even though a lot of happening in glaucoma surgical space, but the trabeculectomy is still one procedure which we all need to know, learn, and also deal with if there's any problem. So in this course, we are basically answering two questions: the why trabeculectomy fails in the first place, and what we can do to keep them functioning if the failure happens or if the failure is expected. So this is basically the scope of today's seminar is. So we have a number of speakers. We will cover the risk factors for the bladder failure. Dr. Purvi, he's not able to come, so I'll cover in my talk. So I'll combine sort of the first two talks. And then we have the pathophysiology. That's very important to understand because whatever actions you take in the post-operative period, if you understand the pathophysiology of the failure, you would be better equipped to deal with that. Then we'll have, if the trabeculectomy is kind of a failing, then how do we resurrect it? And Dr. Sushmita will do how we can do it from Aventurno and needling procedure by Dr. Faisal. And then I'll also do a little bit of the revisions, sort of full surgical revision, how we can do it in a limited fashion so that you have lesser surgical time, lesser complications. And we'll be happy to answer your questions in between or at the end whenever you feel like. So we'll go to the why traps fail. So can we load the other one? This hyperlinked actually, but hyperlink is not working here. So I'll have to depend on the Teams. Okay. All right. So why traps fail? Basically, there are a number of risk factors for failure, and that's what we're going to look at. The pathophysiology and how to identify the blebs that are failing is very important to identify which bleb is going to fail, and so that you can take remedial measures. The glaucoma surgery principles you very well know. We are basically diverting the aqueous from the anterior chamber to the subtenon or subconjunctival space. And because, we hope that in the subconjunctival space, the aqueous will be absorbed and it will flow out. So there's a lower pressure gradient compartment. So because in the AC, the pressure is high, it goes into the lower pressure gradient compartment and it gets absorbed from there. But if for some reason the aqueous is not getting absorbed from there, then the pressure gradient will be abolished and there will not be any filtration. And that is what happens actually when glaucoma fails. So normally, because we have done surgery, we had breached the integrity of the tissue, so normal healing is required. So that will prevent the blood leaks and complications. But sometimes there's excessive healing happens, there's a dense fibrosis, and that actually prevents the filtration from happening, and that is not good for our cause. So good blebs are basically, it's hard to define what is a good bleb, but any bleb which serves your purpose, that means there's a bleb and it is controlling the intraocular pressure would be a good bleb and which is not very thin cystic. But generally speaking, they are kind of low-lying blebs, diffuse, normal vascularity, I would say. And generally, they have microcysts on slit lamp and not very close to the limbus or overriding on the cornea. But unfortunately, many blebs fail and they can look very, very different. Like you have a totally scarred bleb, that looks like there's no bleb at all there. They have cyst formation, then a lot of vascularization. Sometimes the bleb gets very localized. The fluid is coming out, but it's not actually getting drained, and sometimes they become very dysmorphic. So there are a number of ways the bleb can actually fail. But overall, you can see the trabeculectomy failure rate is quite significant, 30 to 50%. Depending on the clinical situation in 3 to 5 years. And a number of factors, so we'll come to the factors, how the blebs fail. So factors could be in the preoperative workup, postoperative or intraoperative. And we actually have to take care of all these factors. And preoperative selection is very important. And there are a number of, you're all well aware of these actually. Young age, black ethnicity, history of previous surgery or cataract surgery, combined surgery, uncontrolled IAP before surgery. Other conditions like uveitis, diabetes, trauma, poor ocular surface, patients on prolonged anti-glaucoma therapy and the lid inflammations, they're all risk factors for failure. So preoperatively, I think they should be treated as far as possible. And intraoperatively, if there's excessive bleeding, excessive cauterization, or there's other complication, flap-related complication that can also contribute towards failure. And then in the post-operative period, things could be like bleb leak, shallow ACs, choroidals, high IOP, and additional surgeries if are required to maintain the integrity of the eye. Again, that will all contribute towards failure. So all these conditions should be handled pre-operatively or during surgery or in the post-operative period. So, bit of the blood physiology. Basically, when you're doing glaucoma surgery, there are three things. So, we are inducing trauma, surgical trauma. There's the aqueous humor which is flowing into the tissue. There may be a foreign body in the form of some suture or some stent. If you are doing a stent surgery, then that would be a large foreign body there. And ultimately, what happens is how the subconjunctival tissue interacts to all these three factors. That's what is going to determine the results. Now, if you have just a conjunctival wound, normally it heals very fast. You do pterygium surgery or you do some conjunctival, graft or something. The conjunctiva actually heals very quickly. Within 7 to 14 days, the wound actually completely heals. But once there is an aqueous getting into the space, it doesn't heal. It takes very long. So the presence of aqueous is very important, and because it has pro-inflammatory cytokines due to the breakdown of the blood-retinal barrier, and they keep the inflammation and keep the wound healing process going for a longer time. And also, flow of aqueous is also known to cause some mechanical stress or the fluid-related stress in the tissue, which activates fibroblasts and converts into myofibroblasts, and they actually proliferate, and they also lead to excessive wound healing. And then with subconjunctival tissue, the interaction with these events, they're more prone to develop again those pro-inflammatory or pro-fibrotic chemicals in that space, which will lead to failure. And also something which we usually don't keep in consideration, which is very important. Also, what are we doing to the blood vessels? Because we are smearing the blood vessels, we are cauterizing them, we are actually physically removing blood vessels in that space to get a good surgical exposure, but that actually leads to more hypoxia and more hypoxia-related events which follow. And also the lymphatics. Lymphatics we normally don't put in the equation, but they are very important because they also help drain, keep the subconjunctival space dry and drain the fluid away from it. So there are a number of factors which are there actually. And if you look at a normal wound healing, so normal wound healing goes through different phases. The coagulative phase that kicks in immediately after the surgery, then you have inflammatory phase, proliferative, and by 2 weeks actually the proliferative phase should start waning off. But in glaucoma surgery, it doesn't go off and it lasts for 2 to 3 weeks and sometimes even longer. So the longer the proliferative and longer the inflammatory phase lasts, the more is going to the scar formation. And in glaucoma surgery, the presence of aqueous delays the remodeling phase. So that's why we have more fibrosis tissue. So wound modulation phase or the remodeling phase is when the excessive scar tissue is actually removed. So there's apoptosis of the excessive fibroblasts, apoptosis of other inflammatory cells, and they will remove from the scene, and the attempt will be made to bring the tissue to as normal as possible. But when there's a flow of aqueous there, these things do not happen naturally, and the whole process gets delayed. So what happens is ultimately there's an exaggerated physiological response. There's a dysregulation of inflammation, extracellular matrix formation, excessive fibrosis, mechanical stress, and ultimately it all builds up into laser. And we have actually now there's enough evidence to suggest that the passage of fluid itself is significant to induce fluid-related stress and cause thickening of the capsule in these eyes. So even if there's less inflammation and other things are normal, if there's a lot of fluids, that can in some patients induce excessive fibrosis by itself. So having understood a little bit of the pathophysiology, important thing is to identify and rescue identify the blebs which are at risk. Now, objective of glaucoma surgery is basically to have a diffuse functioning bleb, and which should cause lower IOP. And typically, they should look like this, a diffuse normal bleb. But reality is that we see very, very different kind of blebs. Now, these are the two eyes which operated on the same day by the same surgeon with the same technique. And this is on day 2 post-operative. Can you guess which eye will be both, which eye would be better than the other, or both will the same, A or B? Can you have a quick hand? Who thinks the A is better, or B is better, or both are the same? So here both kind of look the same. You can't really make out which eye is going to behave in better way. This is after 7 days. So after 7 days, you can see. You have to continue the timing, please. Okay. So after 7 days, what you see is that in the AI, there's some vascularization in the section area. There's some evidence of fibrosis there. Some evidence of fibrosis there, and you can see the vessels are there. But in the B side, B is still not much vascularization. It looks diffuse and pale. So at this stage, which eye you think is better, A or B? A or B? A? B. Okay, so B looks better. Now this is because we are kind of taught there's thin, diffuse, avascular bleb are the good blebs, right? This is what is happening after 14 days. So again, after 14 days, you can see there's a good amount of vascularization in the right eye. You can see there's a fibrosis in the wound area. This was a limbal base flap. Some vessels are there, and VI is still not showing much vascularization, still diffuse, but the bleb is elevated. It has become a little out of focus because the bleb is elevated. Now, what do you think? Is A is going to succeed or B is going to succeed? Any? Who is for A? So B is going to, so you still feel B is going to succeed. Okay, this is what happens 8 weeks down the line. So B becomes an cyst, and A becomes a beautiful bleb which is controlling the pressure 12 millimeters of mercury. So why this happens is because we are taught that a diffuse avascular bleb is a good bleb, but actually it is not. So now I'll go back to these pictures. This is very important to understand, because we see that the vascularization is a bad thing, fibrosis is a bad thing, but we have to understand that these are the part of the normal healing process. Now in this, what is happening is that these vessels which are there in the AI, they are superficial vessels, number one. They are very distinct, right? And they are radially arranged. So they mimic normal conjunctival vessels. So what is happening here is there's an attempt to normalization of the conjunctival vasculature. So if you see a picture like this means this is a normalization of the conjunctival vasculature. And if the normalization happens, that bleb will not fibrose much, because after that, the scar tissue, as you can see, the scar tissue has actually absorbed. So there's a remodeling has happened because of the apoptosis process. The scar has been removed, and you get a beautiful bleb. But on the other hand, what is happening, if you look more carefully, the vessels are stopping at the incision site, so they are not actually coming to the central area, which remains avascular. Now, the central area is remaining avascular, means that area remains hypoxic throughout. So if the area is hypoxic, it will continue to produce those cytokines, VEGF and other stuff, and it will keep the healing process going on. Now, because the central area is now not capable of mounting a normal healing response, it mounts an abnormal healing response. And that is that you get fibrosis around the bleb. It becomes, that's got a wall of ring kind of a thing, and the surgery fails. So what are the indicators of bleb failure? Indicators are like wound leak. That's number one. That's moderate risk of failure. If the bleb is high, anytime the early postoperative it becomes high, it gains in height unexpectedly, there's a moderate risk of failure. If there's an attempt to localization or cyst formation, there's an attempt for failure. Tendon cyst formation, increased bleb vascularity. So I'll tell you there's a difference in the good vascularity and the bad vascularity. And if there's a reduced bleb area, again, there's a risk for failure. And if the bleb in the IOP is high, now this IOP is high, sometimes we deliberately keep the IOP high in the first few days by tightening the suture so that your AC becomes more stable early. But after you have, that phase is over, and after you have removed suture or formed the bleb, in spite of that, if the IOP remains high, that's a strong indicator for failure. So this is kind of a bleb leaks. Now this eye, you can see, sometimes the bleb leaks are very settled, and this conjunctiva was very thin, and there's a needle track actually which is leaking. So it's better to deal with them as soon as possible. So if you see a bleb leak, do whatever method, but it should be dealt with as soon as possible. So we went ahead and we actually sutured the bleb, and in the last lower picture you can see the area where we put additional suture, there's a bit of scar there, but the rest of the bleb has survived and the IOP is good. Now this patient again early post-operative phase, and as you can see on the fluorescein on the there is kind of diffusely leaking. Now this bleb has a very leak, but it's kind of a limbus because this is a limbal phonics-based flap, so sometimes they tend to limbus. So because this is close to the limbus, we could try a contact lens there. We put a contact lens there, and which gave tamponade. So we kept this for 4 weeks. You keep monitoring and keep it for longer time, and this is what happens after 4 weeks. We remove the contact lens, and you have a nice bleb there. The high blebs. Now, if you get a bleb localization, now you can see there's an attempt at, the bleb height is getting and the bleb is getting localized. Now, if you see this kind of picture, these blebs are going to become tenocysts later on. So here, the important thing is to reduce the IOP. That's number one. Number two, you massage these blebs to make them diffuse. So try to break the adhesions, use aqueous in the bleb, as a instrument to do, to tissue dissection around the bleb, and so they will need a lot of kind of a physiotherapy sort of thing for the bleb in the next couple of weeks, so that you can salvage these blebs. And also you have to give some anti-inflammatory therapy. And this is what I mean by bleb, because what you see, I'm squeezing that bleb and pushing the aqueous out from that area. So there are some adhesions here which are broken adhesions, and once you can achieve that, as long as you achieve that, the chances that this bleb is going to survive. But if you can't achieve that, then there will be a problem. Now, this is the differences in the vascularity. So what is the good kind of vascularity and what's the bad kind of a vascularity? I think that we have to understand. Now, this is example I have already shown you. So these are distinct vessels, radial. In between the vessels, the areas look healthy, good. But this is a kind of a bad vascularization. What is happening here is they are angry looking, they are more red, they're kind of dark red in color. They're crisscross, they're not radial, they're crisscross, and they're deeper vessels. So if you have a radial superficial vessels, it doesn't matter how many are there, they are going to eventually absorb. But if you get angry vessels which are crisscross, which indicates a deeper vascularization, those are the vessels which are going to create trouble later on. So here you can remove all the foreign bodies, give steroids, keep IOP low. You may give 5-fluorouracil to stop to halt the process, and it might work. And then if you see a reduction in the bleb area. So here what has happened is the bleb area was something like this, and over a period of time the vessels are slowly growing towards. This is again happening because the central area is ischemic. So it continues to produce VEGF other cytokines, and the process continues until the whole thing is obliterated and you get bleb failure. So in summary, early recognition of bleb failure is important, and the aim is to stabilize AC as soon as possible, attend post-operative complications if any, and bleb appearance, extent and height, vascularity, IOP leaks, and they should be measured, they should be dealt with as soon as possible. And if you do these measures, you can make your bleb survive longer. So thank you very much for this part.